Hello again, everybody. We're going to run through part 12 of our internal medicine review questions. We've got 10 very high yield questions here. If you're running through these questions, make sure, and this goes for questions that you go through on UWorld, make sure you're reasoning through each of the answer choices. Even if you get the answer correct, you need to understand why each of the wrong answer choices are wrong. Because if you can't reason through why each of the wrong answer choices are wrong, you're going to be at risk for falling victim to some of the distractor answer choices on test day. But first, if you haven't had a chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I appreciate all the contributions I can get to help offset the cost of these videos, and I thank all those of you who have already donated. All right, let's start out with question 1. We've got a 50-year-old guy who undergoes a routine screening colonoscopy. During the colonoscopy, you find a 12-millimeter polyp, which the pathologist reports as tubulovillous adenoma. Which of the following is the best next step in the management of this patient? A, follow up in 10 years with a colonoscopy. B, follow up at 5 years. C, follow up at 3 years. D, follow up at 1 year. Or E, follow up at 6 months. Okay, so the answer, C. Follow up in 3 years. Now, this is a tough one, and it isn't the most high yield, but I'm going to tell you this. I go through thousands of test questions through multiple different banks every year, and I don't do any questions that I haven't seen before. So I have seen this come up, so it is fair game, but I'm going to say this is not the most high yield. It is a 99th percentile question. I don't usually do those in my videos, but we're going to talk about it here, because it might actually be useful to you if you're a resident and you're on a GI rotation. So when we do colonoscopies, first of all, you should know that the age we start doing them is now 45 years old. It used to be 50, but now it's 45. So if you're getting close to that age, you've got that to look forward to. Now, this is a lot here. I bold-faced the ones that I think you should memorize because those are the ones that are probably going to come up on your test. I don't expect you're going to have to know a whole lot about this. So first of all, no matter what, colonoscopies are done every 10 years, starting at age 45. That's the maximum you go, is every 10 years. Now, that would be done if there's no polyps or if you find hyperplastic polyps under 1 centimeter. So you could find 6 polyps that are under 1 centimeter, and if they all come back hyperplastic when the pathologist looks at it under the microscope, you're fine. So then you go out 10 years. Now, if you find a hyperplastic polyp that's more than 1 centimeter or 10 millimeters, then you're going to do your follow-up in 3 to 5 years. You won't be asked 3, 4, or 5. It's 3 to 5 years, okay? So that is based on size. Now, tubular adenomas, it's going to depend on the number of adenomas. I don't think you're going to be asked about that, okay? You can memorize that if you want, but I don't think you're going to be asked about. What you might be asked about, like you were in this question, is if it's a villous or tubulovillous adenoma. Remember, villous is villainous. It's the bad polyp, the bad adenoma. So if you find a villous or a tubulovillous adenoma of any size, the follow-up is 3 years. All right. Now, if you find more than 10 adenomas, it's 1 year. I don't think you're going to be asked about that. As far as tubular adenomas, it depends on the number, and I don't think you're going to be asked about that. If you find a large adenoma that's more than 2 centimeters and it has to be removed by piecemeal excision, then it's 6 months. I don't think you'll be asked about that either. What I think you'll be asked about is either this, or this. Okay, so that's what I would suggest you remember. And even then, this is not super high yield. So I included it here because some of you may want to know it. Some of it, you could impress your GI attending, but for the most part, just remember those and you're good to go. Okay, question 2. We got a 48-year-old guy coming into the clinic complaining of constipation for the last 3 weeks. He says he's got hard pebbly stools twice a week. Prior to this, he says that he had soft stools 5 to 6 times per week. He's tried over-the-counter fiber supplements and is drinking 100 ounces of water per day, but it has not helped. He denies changes in weight, blood in the stool, or nausea. His current medications include hydrochlorothiazide for primary hypertension and amitriptyline for tension headache prophylaxis. Vitals are within normal limits. Physical exam is unremarkable, and there's no stool impaction. Which of the following is the best next step in the management of this patient? A, discontinue hydrochlorothiazide. B, discontinue amitriptyline. C, anomanometry. D, colonoscopy. Or E, CT abdomen. Okay, so the answer here, basically what they're asking you is, can you identify the cause of this patient's constipation? B, discontinue amitriptyline. So what's the definition of constipation? Well, what's the normal number of times you should be pooping in a week? So it should be anywhere from 3 times per week, so roughly every other day, once a day, to 3 times per day. Okay, anything outside those parameters, if you're pooping 4 times a day, that's too much. If you're pooping 2 times a week, that's not enough. Well, this guy, twice a week, and they're hard and pebbly. So the hard pebbly part is telling you that not enough water is staying in the colon. Well, what do we know about these drugs? Is hydrochlorothiazide going to constipate you? No, it's going to dehydrate you. Can dehydration cause constipation? It can reduce your stooling, but it's typically not going to constipate you. What about amitriptyline? Yeah, amitriptyline has anticholinergic effects. So it can dry you out, it can constipate you, you might sweat a little less, so you might become hyperthermic if you're exercising. So it has some side effects. Now, discontinuing amitriptyline, is it okay in this patient? Well, he's on amitriptyline for tension headache prophylaxis. If he goes off of it, it's not the end of the world. It's not like he's on it for hypertension or something. He's probably on it because he's had tension headaches, severe ones, that were refractory to ibuprofen. But he can go off that. There are other drugs that can be given for tension headache prophylaxis. Amitriptyline is the first line for tension headache prophylaxis if you're just getting them all the time. So maybe send him to a neurologist, a headache specialist, but you want to discontinue the amitriptyline because he is not pooping enough, and this can be problematic. Also, with the hydrochlorothiazide, yes, it can dry you out, but look how much water he's drinking. He's drinking 100 ounces of water per day. He should not be dry from the hydrochlorothiazide. Anomanometry is kind of a last resort if you've got constipation and you've tried so many different things. You've tried fiber, you've tried water, you've tried discontinuing drugs. That may be then something you do. I don't think on the USMLE that would ever be a right answer choice, but just know it's there for the ultimate workup of constipation. Colonoscopy would be something that you would do if he was constipated and he was losing weight and there was blood in the stool and maybe he's maybe he's a little older, family history of colon cancer. They'll throw those alarm symptoms at you. And then CT abdomen really doesn't have a place for constipation. That's more looking for structural bowel problems. Okay, question 3. A 70-year-old man with hypertension presents to the clinic for follow-up. He was last seen 9 months ago and has been maintained on amlodipine for the past 4 years. He's on sertraline for major depressive disorder, which was diagnosed 15 years ago and has been well controlled. He doesn't smoke, drink alcohol, or use recreational drugs. Vitals are within normal limits, aside from a mildly elevated blood pressure of 133/84. Physical exam reveals a 2/6 systolic ejection murmur at the right second intercostal space. By the way, what is that? Right second intercostal space, systolic ejection murmur, probably aortic stenosis. Lung fields are clear, and there is no peripheral edema. An echo that was performed 2 weeks ago revealed an ejection fraction of 38%. Cardiac stress test was negative for ischemia. Which of the following is the best next step in the management of this patient? A, digoxin, B, hydrochlorothiazide, C, propranolol, D, spironolactone, or E, sacubitril/valsartan. Okay. So the answer, sacubitril/valsartan. What does this patient have? ejection fraction of 38%. So this is a reduced ejection fraction. What we call this is heart failure with reduced ejection fraction, formerly known as systolic heart failure. Now, when you are treating heart failure with reduced ejection fraction, the first drug you go for is something that blocks the angiotensin system, the renin-angiotensin system, whether that be an ACE inhibitor, an angiotensin receptor blocker, but the gold standard nowadays is sacubitril/valsartan. This is marketed as Entresto. Great drug. Really good drug. Okay, so this is the first drug you're going to go for. You're going to use this, get them up to the optimal dosage. You titrate them. You'll have to adjust the dosage. You don't need to know anything about that. Just know that this is the first drug you start them on. Once you titrate them to an optimal dose, then you will start a beta blocker. Okay, you're not going on the Entresto, and then, if they improve their ejection fraction and you stop, they need to be on both. But you don't put them on both right away. You put them on the Entresto first, and then at some point you'll put them on the beta blocker. You do not need to know when. Okay, that will not come up on the USMLE. You just know that both are given, and you start with the sacubitril/valsartan or Entresto first. Now, what about furosemide? Well, furosemide is given if there's fluid overload. All right, so you don't necessarily need to be on that. That would be given if there is fluid overload. They got pedal edema, they've got pulmonary edema, something kind of along those lines. So that's kind of optional. It's for symptomatic control. This little down arrow with the skull and crossbones, that means improves mortality or reduces mortality. So furosemide, because it doesn't do that, it only treats symptoms. You only will use that if they have fluid overload. Now, step 2, if their ejection fraction is less than 35%, which was not this patient, would be to put them on spironolactone. And then step 3, if that is not enough, then you go for the SGLT2 inhibitor. That is like Jardiance. Those are I'm trying to remember the generic, empagliflozin, canagliflozin, they all end in flozin, right? And then supplementary agents, if they can't tolerate Entresto, they can't tolerate ACE inhibitors, they can't tolerate ARBs, you can use isosorbide dinitrate and hydralazine. That may improve mortality, but that's the reason we don't go to that first. We want to get them on an angiotensin inhibitor because those drugs improve mortality, whereas these, they might, but we don't know. Digoxin is going to, again, be used for symptomatic control. It does not give benefit in the mortality department. So I have a video on heart failure. You can go back and watch that, but this is kind of your cheat sheet here. This is sort of the mechanism of how they work. This is how heart failure works. Okay, question 4. We got a 25-year-old guy coming into the clinic complaining of nasal congestion and runny and stuffy nose for the last 10 months. He says that he's also had a cough with increased frequency during this time. He's tried over-the-counter saline spray, which has provided some relief. He can't identify any factors that make it worse. On physical exam, you see boggy appearing nasal turbinates with mild erythema. Which of the following is the best next step in the management of this patient? A, serum allergen-specific IgE antibodies. B, chlorpheniramine. C, intranasal glucocorticoids. D, intranasal ipratropium. Or E, allergy skin testing. Okay, answer here. Intranasal glucocorticoids. What does this guy have? He has rhinitis. What kind of rhinitis? Rhinitis comes in 2 flavors, allergic and non-allergic. So, allergic rhinitis tends to come with other allergy symptoms. This guy only has rhinitis, so it's probably non-allergic. Allergic rhinitis would probably come with conjunctivitis. They may have a history of eczema. They may have a history of asthma. They may have blockage in their ears. They might have like a otitis media with effusion. So that tends to be part of a constellation of other allergic-related symptoms. Whereas with non-allergic rhinitis, it tends to just be isolated rhinitis. Okay, now that is important for you to know because the treatment, the management is a little bit different. So let's take a look. With allergic rhinitis, it tends to be part of a constellation of symptoms. So not only will they have a rhinitis, but they will also tend to have conjunctivitis. They'll have tearing. They may have a scratchy throat. They may have plugged up ears. That is allergic. They may have a history of other allergic disorders like eczema or asthma. Another thing with allergic rhinitis, think of this as just what we often call allergies. Okay? What do we know about allergies? A lot of us have allergies, and a lot of us know what we're allergic to. For instance, when I was as young as 12 years old, I would go up to my aunt's house in northern Minnesota where there's just tons of oak trees and tons of pine trees, tons of allergic related, tons of things that cause allergies. A lot of people know I'm allergic to dust, I'm allergic to pollen, I'm allergic to oak, and they know, right? Or maybe they say, yeah, I get watery eyes, but only in the fall. That points to allergic rhinitis. Whereas with non-allergic rhinitis, it's all the time. It's all the time. They have rhinitis all the time. And it's also only rhinitis. So they have this runny and stuffy nose, they've got the sneezing, they've got the postnasal drip, and it's all the time. Okay, now this guy had a cough, right? Why did he have a cough? Well, anytime you have rhinitis, you got all those secretions have to go somewhere, and they go to the back of the throat a lot of times, and that is postnasal drip. And postnasal drip, also known as upper airway cough syndrome, when it causes cough, is one of the most common causes of chronic cough. That needs to be on your differential. When a patient says, I cough all the time, and it's been months and months, and I just keep coughing, and it's a pain in the butt. Well, you need to think of things. You can think of reflux. Are they on an ACE inhibitor? Do they have these, this rhinitis sort of picture? So distinguishing these two is important. Now, non-allergic may come on in adulthood. Allergic rhinitis tends to come on in childhood. Like I was saying, when I was as early as 12 years old, every time I go up to my aunt's, I would start getting a runny nose, itchy eyes, watery eyes, just miserable, sneezing all the time. That tends to come on in childhood. Kids get allergies all the time, right? Also, the trigger. With non-allergic rhinitis, they don't know what causes it. Allergic rhinitis, when I go up north to my aunt's house, I get it. When I come home, I don't. Non-allergic rhinitis tends to be perennial because it's not triggered by an allergen. Allergic rhinitis, maybe they only get it in the fall. Maybe they only get it in the spring. So it tends to be seasonal. And then with non-allergic rhinitis, that may be all they have, whereas with allergic rhinitis, they tend to have other allergic disorders, conjunctivitis. They may have asthma. They may have eczema, or what will probably be described to you on your test as atopic dermatitis. Okay, so what is the management? Now let's go back and think of allergic rhinitis. Well, if you have allergic rhinitis, you probably have conjunctivitis too. So if that is the case, why not kill two birds with one stone and go with an oral antihistamine? It's going to kill both, right? So you can use a first generation or a second generation antihistamine. Now, why was chlorpheniramine the wrong answer? Because this patient has non-allergic rhinitis. They only have rhinitis. So why would we give them an oral medication if we can give them something intranasal? Also consider that chlorpheniramine is a first generation antihistamine. And you know what those first generation antihistamines do. If you take one of the more common first generation antihistamines like Benadryl or diphenhydramine, it makes you sedated, it makes you tired, it dries you up, it has anticholinergic properties. So you want to avoid that. Benadryl is great if you want to go to sleep, but if you're taking it at 9 a.m. and go to work, you're probably not going to be having a good time. So you want to avoid that, even for allergic rhinitis. I would go with something like loratadine, like Claritin. I would not go with this. Serum allergen-specific IgE antibodies and allergy skin testing. That's if a patient has allergies and you want to know what they're allergic to. Well, this patient does not have allergic rhinitis, so these are out. And then intranasal ipratropium. Why not that? Well, intranasal ipratropium is less effective than both intranasal antihistamines and intranasal glucocorticoids, so that is out. Now, if intranasal antihistamines was a choice, like azelastein, also known as Astapro, that could be a right answer choice, but that wasn't given to you. So you're going to go with intranasal glucocorticoids. So with non-allergic rhinitis, you can do intranasal antihistamines like Astapro. You can do intranasal glucocorticoids. If neither of those work, you can combine them. So that is your treatment for non-allergic rhinitis. With allergic rhinitis, again, we're going to go with PO antihistamines because it just knocks both of them out. Just Claritin. You can get it over the counter, and most people know this. They've got allergies, they go for Claritin. Claritin is marketed all the time. You see those commercials come out in the spring and the fall because they know people get their allergies around then. Okay, question 5. A 19-year-old woman presents to the ED due to fever and fatigue. Her brother says that she's been sleeping a lot over the past couple weeks, and she's also complained of a headache and a fever at home, which was measured as high as 101.3. She's got no significant past medical history, and she's received all recommended vaccinations. Her brother says that their grandmother is currently visiting from Vietnam for the past 3 weeks, and she has recently had a cold. Patient works as a veterinary technician. Vitals are within normal limits, except for a temperature of 100.4. She's somnolent in response to painful stimuli. There's resistance to passive neck flexion. Her right eye is deviated medially, and fundoscopic exam reveals several ill-defined raised yellow-white nodules around the optic discs bilaterally. CT scan of the head reveals basilar meningeal enhancement. Lumbar puncture is performed, and CSF analysis reveals a glucose of 16, protein of 335, leukocytes of 210 with 88% lymphocytes. You will be given, by the way, the normal values of CSF parameters on your exam. So don't worry about knowing the numbers there. Which of the following is most likely to yield the diagnosis in this patient? A, toxoplasma antibody. B, CSF acid-fast bacilli staining in culture. C, India ink preparation of CSF. D, West Nile virus antibody. Or E, cytomegalovirus PCR of CSF. So this is one of those second order questions. And by the way, this is a question where we're going to go on from this to a follow-up question. So remember, on USMLE, you can get a question, and then they're going to say, you have to pick, and then you can't go back, because typically what they're going to do is they're going to give you, here's the result of the test you just ordered, now what? Because that's kind of how it works in real life, right? So what is our answer here? So we have a number of hints. So first of all, let's give you the answer here. So it is a CSF acid-fast bacilli staining culture. Now, on the USMLE, when they're getting at tuberculosis, they're going to give it to you in one of two ways. Either they're exposed to somebody who's from an endemic country, or they went to an endemic country and came back. So remember, this is the USMLE, and people don't get tuberculosis in the US by being around other Americans. It just doesn't happen because it's not endemic to the United States. It is endemic to places like Southeast Asia, South Asia, South America, Africa. This is places where it just circulates around more, okay? Generally, what I like to tell students, and I know this isn't exactly politically correct, is if it's a poor country, you're more likely to have tuberculosis. And I know that's not really nice. I shouldn't say that, but that's kind of how it works. So, you're talking about countries like Vietnam, Bangladesh, India, Central Africa, South America. These are just tend to be countries where it circulates a little more. So whenever you hear a country given and it's a poor country, you got to start thinking about those zebra disorders. Things like, schistosomiasis or Chagas disease or ascariasis. You just don't get it in the U.S. So that is a hint. And then another one that a lot of people don't know is basilar meningeal enhancement. That kind of gives away the tuberculous meningitis. And then, you got this grandma visiting with a cold. Well, if they say a cold, you don't really know if that's what it is. But the real hint here is the CSF analysis. And you have to know how to interpret CSF. And we will run through that, but that is so high yield. I guarantee you on your test, you will get a question that will require you to identify CSF. So ignore that. Let's just take a look at the CSF analysis. So these are the three that you're going to need to distinguish. Remember, you will be given normal on your exam. So with bacterial meningitis, so something like meningococcal meningitis, strep pneumomeningitis, what you're going to see is neutrophils. So you'll have a very high white count and you'll have neutrophils. Remember, neutrophils kill most bacteria. You're also going to see a low glucose. Why? Well, anytime you have something living in your CSF, any kind of bacteria, your glucose is going to drop. Now, why? Because they eat glucose. They're bacteria. They eat glucose. Viruses, on the other hand, are not life forms. Viruses are just encapsulated genetic material, so they don't need glucose. So with bacterial and tuberculous meningitis, you're going to have a low glucose. Now with bacterial meningitis, what you'll also see is a high protein. Okay, so those are the three things you'll see in bacterial meningitis: a high white count with neutrophils, low glucose, high protein. Now with tuberculous meningitis, a little bit different. The white count is going to be elevated, but not very elevated. And what you're going to have is lymphocytes. Now, the giveaway between tuberculous and viral, they both have lymphocytes, but with tuberculous, because you're dealing with a life form, a bacteria, your glucose is going to be low, whereas with viral, it's not. It's going to be normal. So viral looks pretty normal, other than you have a little bit protein, because there are proteins in viruses, but that white count is going to be lymphocytes, and the glucose, most importantly, is going to be normal. Okay, so you need to kind of, if you understand the concepts behind this, it'll make a little bit more sense. Now, I include Guillain-Barré syndrome here because that's another place where you're going to get a lumbar puncture and analyze the CSF fluid. This is not meningitis. Guillain-Barré syndrome does not cause meningitis. But what you see here with Guillain-Barré syndrome, it's just pathognomonic, is the cytoalbuminologic, I can't even spell, albuminologic dissociation. So basically what that means is you've got high protein, but a normal cell count. And typically we don't see that. I mean, see here, high protein, high protein, high protein, high cell count, high cell count, high cell count. Well, here you have high protein, normal cell count. That is pathognomonic for Guillain-Barré syndrome. I just included it here just to point that out. Guillain-Barré syndrome does not cause meningitis, okay? All right, let's go back to a follow-up question. CSF samples are sent for acid-fast bacilli staining and culture. 2 hours later, the parents arrive, and through the use of an interpreter, it's revealed that the grandfather, I don't know why I changed it to grandmother, okay? The grandparent had been diagnosed with latent TB 20 years ago, which was treated with 6 months of isoniazid. Which of the following is most accurate about the management of this patient? A, multi-drug tuberculosis treatment for 6 months is adequate. B, intrathecal administration of anti-TB drugs shortens the treatment duration. C, long-term neurologic sequelae are unlikely after prompt initiation of treatment. D, anti-tuberculosis treatment should be initiated after bacteriologic confirmation. Or E, adjunctive glucocorticoids are likely to reduce morbidity and mortality. Okay. So the answer here is E. Adjunctive glucocorticoids are likely to reduce morbidity and mortality. Okay, let's go through the wrong answer choices here. So what about A? Multi-drug anti-tuberculosis treatment for 6 months is adequate. Okay, so grandpa/grandma was on 6 months of isoniazid. Is that a correct management of latent tuberculosis? Isoniazid for 9 months. Isoniazid for 9 months. That's standard. Now, there are other treatments for latent TB. You can add rifapentine, and that can shorten the duration. But if it's just isoniazid for 6 months, that is not enough. So either they had a bad doctor or they stopped taking their medication, but that was not enough. So that's probably why this grandparent is now having active TB. So that is wrong. You need to know your treatment for latent TB. It's isoniazid for 9 months. And then for active TB, obviously, it's RIPE therapy. Now, this patient has tuberculous meningitis, so she's going to be on 2 months of RIPE, and she's going to be on 9 to 12 months of rifampin and isoniazid. And then, of course, you add B6 anytime you're on isoniazid. Now, that's before we'll talk more about the treatment of tuberculous meningitis in a little bit. B, intrathecal administration of antitubercular drugs shortens treatment duration. Would we ever give intrathecal administration of antitubercular drugs? I mean, theoretically you can, but you don't need to because rifampin, isoniazid, and pyrazinamide have really good CSF penetration. So just taking those drugs orally is totally okay. What about long-term neurologic sequelae? If we start the treatment, does that mean that the long-term neurologic sequelae are unlikely? Well, they're less likely, but they're not unlikely. This is a very high-risk disorder. This is very dangerous. Okay, and then D, treatment should be initiated after bacteriologic confirmation. No. It should be treated as soon as you can make a presumptive diagnosis. Are you going to do a culture? Sure. But as soon as you make that diagnosis based on the CT scan, based on the CSF analysis, based on the history, once you think, yeah, this is tuberculous meningitis, you are not waiting for cultures. You are going to treat now. Plus, these drugs don't have terrible side effects, so, you can go for it. The benefits outweigh the risks. Okay, let's go back real quick to why these were wrong answer choices. So what about toxoplasma? How do we know it's not toxoplasma? Toxoplasma is usually asymptomatic in immunocompetent people. Occasionally, it can cause a flu-like illness, but this is only going to cause severe disease in immunocompromised people. It can cause an encephalitis, but it's only going to be in immunocompromised people, AIDS patients, for instance. What about India ink preparation? What would that look for? That would look for cryptococcal meningitis. Again, that is seen in very immunocompromised people. CD4 count under 200, even lower than that. So that is not this patient. This patient is otherwise healthy. What about West Nile antibody? So West Nile virus does not cause retinitis. It doesn't cause basal or meningeal enhancement. And the CSF would show a viral picture. And we didn't have a viral picture here, okay, because we had a low glucose. So that is not it. And then what about CMV PCR? So CMV causes a mono-like syndrome. It, again, is not going to cause retinitis or encephalitis. That's rare in healthy patients. Okay, so tuberculous meningitis, it's got a subacute onset. They'll have these prodromal symptoms that often will include like a headache and a low-grade fever and fatigue, and then they'll progress to these meningeal symptoms and these fever, where they're getting the nuchal rigidity and the vomiting and confusion. Eventually, it'll cause encephalitis. But this basal or meningeal enhancement is a good hint. And then, again, you have to know this. This is so important. You will get tested on this. Okay, question 7. A 67-year-old woman comes into the ED complaining of shortness of breath. After 45 minutes ago, she said her chest began feeling tight when she tried to breathe. And let's just add here, it hurts to breathe. She has a past medical history of hypertension and mild aortic stenosis that was diagnosed on echo last year. 40-pack year smoking history, vitals 79/52, heart rate 119 and regular, respirations 29, temperature 98.6, saturation 79 on room air. Supplemental oxygen is administered and saturation improves to 95%. Physical exam reveals an anxious but cooperative woman. Lungs are clear to auscultation, tachycardia with a 2/6 systolic ejection murmur. That's the aortic stenosis. Regular rhythm. Remainder of the exam is normal. EKG is shown. I'll show it to you in a little bit. Fluids are administered. Which of the following is the best next step in the management of this patient? Okay, let's quickly look at that EKG. Okay, so here it is. You can pause it, look for what's abnormal. Okay, let's go back now. So is it CT angio, VQ scan, rapid sequence intubation, additional fluids, blood culture, and broad spectrum antibiotics, or immediate transthoracic echo? Okay, so the answer is transthoracic echo. What does this patient have? So this patient most likely has a pulmonary embolism. Why? Because pulmonary embolism is a big cause of sudden shortness of breath, sudden dyspnea, and sudden shock. This patient has that shortness of breath. I said they have dyspnea, and then that low blood pressure. This is a massive pulmonary embolism that's blocking outflow from the right side of the heart, thus reducing flow to the left side of the heart. Okay, so we're going to move on now to a follow-up question. Echo and lower extremity Doppler are performed, revealing a filling defect of the right external iliac vein. Which of the following findings is most likely to be present on echo? A small underfilled right ventricle, B, a small underfilled left ventricle, C, a thickened right ventricular wall, D, pericardial effusion, or E, left ventricular hypokinesis. Answer: small underfilled left ventricle. So what's the pattern going on here? So when you have a pulmonary embolism, it's going to block the pulmonary arteries. Oh no, my pen's not working. All right, let me see if I can fix this. Okay, I'm going to have to go without a pen. So when you have an underfilled left ventricle, it's because you're not getting blood from the right heart to the pulmonary circulation. And that is because you have a blockage in the pulmonary artery. That's the pulmonary embolism. And so because there's blockage from the right heart, you're not getting blood into the left heart. And so that is going to be your small underfilled left ventricle. When would we see a small underfilled right ventricle? Well, that would be if you just don't have blood going to the right ventricle. So it'd be like a hypovolemic shock, for instance. What about C? A thickened right ventricular wall. That would be something that would happen over a long period of time where you have a right ventricular outflow obstruction, whether that be from a thickened valve or from chronic pulmonary hypertension, and the heart has to work harder over a long period of time, not over this sudden acute period. That would cause the thickened right ventricular wall. What about pericardial effusion? What would we expect to see there? So on echo, we would expect to see fluid around the heart. Furthermore, on EKG, we would expect to see a decreased QRS voltage, maybe electrical alternance. And also, this would not typically cause chest pain, dyspnea, shortness of breath, and so forth. What about left ventricular hypokinesis? Where would we see that? So that we would probably see in an MI. Maybe we would see that in Takotsubo cardiomyopathy. But on EKG, we would expect to see ST segment elevation. And this would also tend to be apical hypokinesis rather than right ventricular hypokinesis. So let's go back here and look at some of these wrong answer choices. So CT angiography, why wouldn't we do that? Well, this patient's not stable. Do we ever want to do imaging in a patient that's unstable? Maybe if it's an ultrasound, but we don't want to send them to a radiology suite. That would be a bad idea. What about VQ scan? Again, imaging, it takes too long, and that one even takes longer. What about rapid sequence intubation? We generally want to avoid intubation in patients with right ventricular failure because that's going to increase the right ventricular afterload, and it's also going to decrease venous return, and both of those are going to worsen the hypotension. So we don't really want to do that unless we absolutely have to. Furthermore, her respiratory distress can easily be addressed by treating the pulmonary embolism, which we know she's got based on the entire presentation. And so by doing fibrinolysis, you will immediately treat the hypotension. And then what about fluids, blood cultures, and broad spectrum antibiotics? That would be if there's pneumonia, right? And she does not have pneumonia. She does not have fever. She does not have sepsis. She has a low blood pressure, but it's not from sepsis. So here's our approach to suspected pulmonary embolism. Again here, if they're hemodynamic, oh, my pen came back, great. So if they're hemodynamically stable, they've got all this stuff here that she had. Okay, my pen, I think, did I fix it? Yes, okay. So sudden onset dyspnea, pleuritic chest pain, tachycardia, hypotension, those are all signs of a pulmonary embolism, or really a massive pulmonary embolism if they have hypotension, hemodynamic instability. The EKG also points towards a pulmonary embolism. Let's go back and look at that EKG, by the way. So what do we see here? This is right axis deviation. So normally in lead 1, you would expect to see your QRS complex like that. And lead 2, you would expect to see it like this. Well, if your QRS complex is more coming down and this one's coming up, so they're kind of pointing inward, that is right axis deviation. If they're the opposite, if this one's coming down and this one's going up, that's left axis deviation. So what you see here, this is right axis deviation. What about the precordial leads? What would we see there? T-wave inversion. So T-waves in the precordial leads should be coming up. Well, this one's going down, this one's going down, this one's really going down, this one's going down, this one's going down, and this one, it's kind of hard to see. It's kind of flat. So we have T-wave inversion, we have right axis deviation that all points towards right heart strain. And that's what we would expect to see in a pulmonary embolism. So going back to the workup here, if they're hemodynamically stable, you'll assess the pretest probability based on the Wells score. Personally, I don't put a whole lot of stock in that. I like to use my intuition, but I will give you how to do the Wells score if you want to memorize that. On your exam, it will be abundantly clear if the patient has, if they're at high risk for pulmonary embolism. If they have a low risk, some say less than 4, others say less than 6, you would get a D-dimer. So if they, you're kind of on the fence of whether this could be a pulmonary embolism or maybe something else, just get a D-dimer. If the D-dimer is high, then you're going to get imaging. Or if their Wells score is really high, you'll get imaging. Let's say they've got all the symptoms of a DVT, they've got pulmonary embolism symptoms, they've got cancer, they've been sitting in the hospital for a long time. That's pulmonary embolism. They got pulmonary embolism. So if they've got a high likelihood, skip the D-dimer, go to imaging. Okay, so that's kind of how we're working here. If their D-dimer is low, they don't have pulmonary embolism. If the imaging is consistent with pulmonary embolism, you have confirmed your diagnosis, go to treatment. What if they're hemodynamically unstable? If a patient with suspected pulmonary embolism is hemodynamically unstable, your next test is an emergent transthoracic echo. You've got to do it. You can't just fibrinolyse patients because you think they have pulmonary embolism. You need some objective evidence. We're not going to wait for a D-dimer. We are not going to send them off for imaging. We're going to get a transthoracic echo. You can do it by bedside. It's very easy, and you're done. You can make your diagnosis based on the fact that they have cardiac dysfunction, namely right ventricular dilation and hypokinesis. They got that. It's a massive pulmonary embolism based on the fact they're hemodynamically unstable. If the transthoracic echo is normal, they probably don't have a pulmonary embolism. This is probably some other form of shock. Okay? So this is your Wells criteria. This patient, they had the DVT when we did the Doppler. She had the heart rate of over 100. She didn't have this. She had this. She didn't have clinical signs of a DVT. Alternate diagnosis less likely? Really, no, because she had the dyspnea. She had the EKG. She had the sudden onset shortness of breath. She had the low blood pressure. And then hemoptysis, no, and cancer, no. So you total all of what she's got, well, she's got 6. So we really don't need to do a D-dimer. Again, Wells criteria, I never personally memorize that because in the hospital, we have a calculator, you can do it on your phone. And on the test, they're going to make it really, really clear. I've never come across a test question where I had to sit down and think, I should use the Wells score here. Now, they're typically going to be very straightforward. But if you want to memorize this, by all means. But USMLE tests a lot of stuff. You got a limited amount of time. I don't know if I'd memorize this stuff, but up to you. Okay, question 9. 55-year-old woman presents to the ED in Arizona complaining of a rash. She's from Vermont and she's on vacation. She noticed the rash on her face and forearms and became very concerned, prompting her to visit the ED. 3 weeks ago, her primary care physician put her on a medication for hypertension, but she can't remember the name of it, and there are no medical records on file. Which of the following drugs is most likely responsible for this patient's presentation? A, furosemide, B, lisinopril, C, hydrochlorothiazide, D, amlodipine, or E, propranolol? This is a classic step 3 question. Classic, where they're asking you about side effects. Step 2 doesn't do that quite as much, but it is important to know because they can. But step 3 likes to do this more. Okay, what's the answer? Hydrochlorothiazide. Okay, what's the hint? A rash on the face. Oh, now my pen's not working again. Darn it. Okay, so a rash on the face and forearms. What do we know about the face and forearms? She is in Arizona, and she's got a rash on her face and forearms. Where do you think that's coming from? It's coming from the sun. Those are sun-exposed areas. So what do we know about one of these drugs? Hydrochlorothiazide makes you photosensitive. So there are a number of drugs that do that. Hydrochlorothiazide is a sulfonamide drug. So any of those sulfonamide drugs, whether that be Bactrim, you're on that for a long time, sulfasalazine, maybe you're on that for inflammatory bowel disease. Hydrochlorothiazide is a big one. Often these two drugs, like lisinopril and hydrochlorothiazide, will be combined. So it is hydrochlorothiazide. This will make you susceptible essentially to sunburns or to sun-induced rashes. So that is the answer. But let's look at our adverse effects from common antihypertensives. So ACE inhibitors famously cause cough. Typically that is limited. It may go away, but some patients it doesn't and they have to switch off of it. It can cause hyperkalemia because it reduces the amount of aldosterone, and in rare cases can cause angioedema, and that is absolutely an indicator to quit it. Angiotensin receptor blockers, a little bit better side effect profile, doesn't cause the cough, less likely to cause the angioedema. Hyperkalemia is a side effect, but it's less likely to do that than the ACE inhibitors. Oftentimes, we start a patient on an ACE inhibitor first. If they can't tolerate it, then we go to an angiotensin receptor blocker. Beta blockers. So bronchospasm is the big one. My pen is back. I do not understand this. I'm telling you, folks. Okay, so bronchospasm is a famous side effect of beta blockers. You may want to avoid that in a patient with asthma or COPD because they've already got problems with their airways. Can cause sexual dysfunction as well. Calcium channel blockers, remember those come in 2 flavors. Dihydropyridines, so amlodipine. That can cause pedal edema or headache, but generally those are pretty well tolerated. The non-dihydropyridines, verapamil, diltiazem, can cause constipation or headache respectively. Thiazide diuretics. Well, we saw here photosensitivity, but it can also cause hypokalemia. You're wasting potassium in your filtrate. Can cause an allergic reaction. All the sulfa drugs can cause allergic reactions. I'm personally allergic to, I had Bactrim when I was a baby and broke out in hives and wheezing and shit. So, sorry. So that is a drug that causes a lot of allergic reactions. Any kind of diuretic can raise your risk of gout because it dehydrates you. Loop diuretics, not going to cause the photosensitivity or the allergic reaction so much, but can cause nephrolithiasis because loop diuretics inhibit the reabsorption of calcium. So you have more calcium in your filtrate, can precipitate, cause a kidney stone. Okay, let's go into our last question. A 60-year-old guy comes into the ED complaining of chest pain that occurred 3 hours ago while at the mall with his daughter. He experienced dull substernal pain that radiated to the upper left shoulder and down the arm. It went away after 10 minutes while sitting on a bench. He denies shortness of breath, sweating, palpitations, and lightheadedness. He had a similar episode last week, which occurred while golfing with his coworkers. Past medical history is significant for hypertension and osteoarthritis. Medications include propranolol and ibuprofen. He ambulates unassisted at home, but uses a cane while walking long distances. He does not smoke, drink alcohol, and uses cannabis to help him sleep. Vitals are essentially within normal limits. Physical exam is unremarkable. EKG shows normal sinus rhythm with no ST elevations. Cardiac enzymes are normal. Chest x-ray is unremarkable. What's the best next step in the management of this patient? Coronary angiogram, 24-hour Holter monitoring, referral to vascular surgery, adenosine myocardial perfusion imaging, or exercise EKG. All right. So the answer here, adenosine myocardial perfusion imaging. What do we know we've got to do in this patient? First of all, this guy came in with chest pain, or he had chest pain. Anytime somebody comes in with chest pain or with recent chest pain, got to work them up for an MI. Okay, so you're getting an EKG, you're getting a chest x-ray, you're getting enzymes. Okay, you always have to do that. If they're coming in with active chest pain, also make sure you're giving them oxygen and aspirin and nitrates. So very, very important. But this guy came in, yes, we worked him up for an MI. He didn't have that. So what do we know about this guy? He has chest pain and it goes away when he relaxes. That is stable angina. Okay, my pen's gone now. Oh, okay, so he's got stable angina. Stable angina is chest pain in that classic distribution that goes away when you relax. Angina is on the less severe end of our acute coronary syndromes. So that ranges from stable angina, unstable angina, and STEMI. So he's got stable angina. Well, that's an acute coronary syndrome. So that means we're concerned about the possibility of blockage. So we have to work that up. And what do we do to work up angina? The first thing we do, you're not going to do it in the ED, but the first thing that we do is a stress test. Now, there are two kinds of stress tests that you can do. There's the pharmacologic stress test and the exercise stress test. Well, what do we know about this guy? He has to use a cane when he walks long distances. Do you think he's going to be able to get on a treadmill and jog? No. He's got osteoarthritis. He's not going to be able to do that. You have to actually exert yourself pretty good on those exercise stress tests. So fortunately, we have another option. What we can do is we can do an adenosine injection. And what that does is it dilates your vessels. Now, that's going to mean that your cleaner vessels, I'm sorry, I can't draw for you. Your cleaner vessels are going to dilate and your clogged vessels are going to dilate, but your cleaner vessels are going to dilate more. So what that means is that you're going to have a relatively high blood flow to your clean vessels and a relatively low blood flow, that's the important part, to your clogged vessels. And that will induce an ischemia. We will see temporary ST elevations in the vessels that we're concerned about. It doesn't matter which ones, you just need to know that you'll have ST elevation, and that then is an indicator to do more testing. So what are we going to do? If the patient is able to exercise, it's an exercise EKG. It's easier to do. There's fewer things that can go wrong. You do that ideally. If they cannot exercise, whether it's because they're 400 pounds, whether it's because they can't, they've got osteoarthritis, anything like that, bound to a wheelchair, then it's a pharmacologic stress test. Once you do that, if you have no significant coronary artery disease, they had no ST elevations, then it's risk factor reduction. So what we can do for them is we can give them a beta blocker to improve their exercise tolerance, their angina. It reduces wall stress. It's going to make them less likely to have chest pain. We'll check their lipid panel. If their cholesterol's elevated, we'll start them on a statin. You're just kind of reducing the risk factors. Lifestyle modifications, lose weight, stop smoking, all that stuff. If they do have signs of coronary artery disease, signs of blockage, then not only do we do medical management, like I said earlier, but we're also typically going to do, it's back now, we're also going to do a coronary angiogram, okay? And what that is intended to do is to determine how much blockage. Is there an indication to go further and to do revascularization? If there is, we want to do that because we don't want them to have an MI. So these wrong answer choices, coronary angiography, we would do that after he has a stress test and only if it demonstrates coronary artery disease. So that's out. Premature. Now it's gone. 24-hour Holter monitoring, that is for arrhythmia. So if this guy had syncope, he passed out at the mall, he passed out on the golf course, and then we did an EKG and it was normal, then we would send him home on a Holter monitor, and maybe catch the arrhythmia. Because, these arrhythmias that cause syncope, they typically come and go. And what's the likelihood on an EKG that you do for 30 seconds in the ED? You're probably not going to catch it. So we do the Holter monitor. Referral to vascular surgery, that would be the last step. After the stress test, after the coronary angiogram, then we may refer to vascular surgery or to interventional radiology, depending on what route we want to go. If we want to do CABG, we're going to send them to vascular surgery. If we want to do a stent, oftentimes the interventional radiologist can do that. You won't be asked to choose between the two. And then exercise EKG, obviously that's wrong because he can't do it. He's got osteoarthritis. He walks with a cane. He's not going to be able to jog.